Mr. Johnson has no relevant financial relationships. We love to see it. Without further ado, I will introduce Michael Johnson. Michael Johnson is a lawyer that practices at the intersection of healthcare, employment, and small business law. His law firm, Michael Johnson Legal, primarily represents physicians in evaluating and negotiating all of the different ways physicians contract for their work, including employment, practice ownership, 1099, locums, per diem, etc. His passion is helping early career physicians make thoughtful decisions on their first contract and navigate the transition from training. I will now pass the control over to Mr. Johnson to begin the presentation.
Awesome. Good morning, everybody. Let me do share screen. Okay. And
we're seeing your presenter view again.
Okay, perfect. Let me flip it around then. Okay. Okay, so that should be on my presentation, I believe, correct?
Yes, looking good.
Okay, cool. So thank you so much, everybody, for having me. My name is Michael Johnson. I own a small law firm called Michael Johnson Legal, and our primary practice area is helping primarily first contract physicians that are evaluating, negotiating, and then sometimes enforcing physician contracts. I help physicians in all specialties and across the country. But I went to Tulane for law school and practiced there. My wife went to LSU for medical school and then psychiatry residency. A few years ago, we moved to Milwaukee, but I actively work with a lot of physicians that are leaving LSU or Tulane or throughout Louisiana and really throughout the country, just making thoughtful decisions on their first contracts. I know we have kind of a mixed group here. Some folks that are out of training, maybe some folks that actually own private practices, maybe some folks in academics. So most of what I'm going to talk about is kind of geared towards residents and fellows, but it's important for everybody to know and understand for renegotiation purposes. And also, if you're looking to hire somebody out of training, this is the type of information that, you know, someone who's thoughtfully trying to navigate this might be considering. So it's important for everyone to understand how physician contracts can affect your career goals and your life plans. Let me go back on share screen. Okay. Okay.
We're good.
Perfect. I'll also PDF the slides and I can send them your way if you'd like to review. Quick disclaimer before we get started. Listening to this presentation doesn't make me your lawyer. It's not intended to be legal advice that's specific to any one person's situation. Everybody's a little bit different. You'll hear me say a lot of maybe qualifying words like usually or normally or rarely, but there's never an absolute in the law and in negotiating deals. So I would encourage you to not take this as perfectly aligned with your situation and to get legal counsel to handle contract matters. If you like some more resources, I have a blog at michaeljohnsonlegal.com. I also have an Instagram page. I have a lot of fun with this. So if you'd like to follow me on Instagram, I'm at Physician Contracts, incredibly obvious name. I usually go on and post a bunch of videos and reels and just talking about physician contract issues. If you have any questions, feel free to reach out to me through Instagram. Also, before we get started, feel free to ask questions as we go along. If it's possible to unmute yourself and then ask it that way, that's fine. But if you want to also put it in the chat, that's also fine as well. We can handle however it makes the most sense for you. But I'd love questions as we go. We don't have to wait to the end for presentation. I have enough information to talk for about 10 hours if I wanted to. I won't do that to you, don't worry. But we can turn it into Q&A really on any slide at any time, okay? At its core, physician contracts are a tool that you can use to execute your life plan. These are not like the click-through in-user agreements that you see on your iPhone or that maybe some large employers might make you feel like they are. There's a lot of important information in there. Frankly, they're not really looked at or used when everything is going well, but you want to know what's in there when things maybe don't go so well, or when it's time to enforce or time to potentially pivot with your career, change jobs, or if there is some sort of dispute. That's when it becomes important. Whenever I have an initial consult with a prospective client, the first question that I ask is, what do you want your life to look like? What do you want your career and what are your life goals with this next transition in your life? We want to take your goals and then compare them to what the contract says and make sure that those match. A lot of times there is a disconnect between those, and we want to try to identify that and see if we can close down those gaps through evaluation and negotiation. We'll talk about why and how to do that as we move forward. First things first, before we jump into the details, I get a lot of this question. Michael, does the contract really matter? I interview with a bunch of upper levels, a bunch of attendings, all the physicians in this particular employer. I'm thinking more of like large employers right now, but all the physicians told me what the job is. Like, isn't that contract just the lawyer legalese for the lawyers to deal with? Does it really have an impact? It does, because anything that was told to you during the interview process is not actually enforceable. Only what the contract says is enforceable. So let's say you're taking a job under the promise, the interview promise that it offers a 4-day work week and something specific about staffing and like your schedule template control, say, for example, maybe something about call. Those operational details are typically not included in the contract. For example, a typical call schedule promised during the interview process is call is never worse than Q, whatever, we don't do call or something. However, the contract will often say call shall be determined in the sole discretion of the employer. So for things like that, if the employer wants to change their mind and do call differently in the future, like which one is enforceable, the promise during the interview process, or is it what is actually written in the contract? This section is very, very common in physician contracts and really just all business contracts. Okay. This section speaks to what is enforceable and what's not. It just confirms that nothing that was promised to you, either oral or written before you sign the contract, is actually enforceable. Another thing I run into a lot, especially when you're dealing with larger employers, you'll have typically a job posting that has some information about the job. You might have some email exchanges and some interview promises about some of the details of the job. You might have an offer letter that speaks to some other important details. Then you have the contract, okay? The folks that write these in large employers often don't talk to each other. Like, the lawyer that writes the contract doesn't always interface with the marketing expert that writes the job posting. Sometimes these documents just don't match at all. So please do not rely on information that was provided to you before the contract, because the contract can say something very different, and it's just a lot of times larger employers are not paying that close attention to it. Often smaller, like physician-owned private practices are paying very close attention. The owner is doing all of those things like all at once. So usually it's a little bit more accurate, but keep in mind that the contract itself is important and should be reviewed and at a minimum compared to your understanding of the job from the interview process. On a macro level, I like to think about physician contracts as the Trinity, okay? Not bell pepper and onion and celery, but compensation, obligations, and leverage and exit. Okay, at a macro level, a good physician contract should be structured in a way that an unfamiliar reader can understand what you're required to do, the work obligations, what you will be paid to do it, the compensation piece, and what happens when you want to leave, leverage and exit. These seem like very simple questions. Like, Michael, why is there like 15 to 30 page contracts that try to answer these very, very simple questions? Like, we should be able to do that in like a couple of sentences. But for physicians, particularly those that are employed by a system or employed by a private practice, employed in some way, answering these questions becomes very difficult. There's a lot of moving parts for compensation. There's a lot of details that go into explaining and defining what you're actually required to do for a particular job. And then the exit strategy pieces are often the most overlooked aspects of physician contracts. Physician contracts are often structured in a way that makes it more difficult for you to leave. Okay. Turnover is exceedingly expensive in the physician world. The amount of money it costs to bring on a new physician, get their resources, get everything set up for them, get their EMR set up, get hospital credentialing, get privileges, get approved with various payors, all the paperwork, admin, everything that goes into bringing on a new physician. Not to mention marketing. I don't know if anybody has been on the other side of like a medicus firm, like online marketing attempt to hire a physician, but at a minimum, you're looking at probably $25,000 to $70,000 a pop. Like, it's a lot, not to mention the time and the downtime. So there's a ton of money that goes into hiring first contract physician, all physicians, but thinking primarily about first contract physicians. There is a ton of money that goes into this. Often employers, and then often when you step in, the odds of you seeing like 20 new patients on day one and completely ramping up immediately are relatively low. That's like burnout central, right? So there's usually a negative delta in your compensation to collections in the very beginning. So it's a pretty big investment. So a lot of employers want to build into their contracts ways to reduce the risk that you're going to leave. We're going to talk about the details of physician contracts, but on a macro level, it's incredibly expensive to recruit you and hire you. And then also when you leave, it's incredibly expensive to replace you. The resources that go into that are very painful. So an issue that's often overlooked is what are the rules upon exit? A lot of first contract physicians are thinking, Michael, this is my dream job. I've been waiting for decades for this opportunity. Like, it is so cool. I could never imagine leaving this job. It's exactly what I want. But unfortunately, about 40% of physicians change jobs within the first 2 to 5 years. A couple different, polls or whatever that are out there. It depends on who you ask and what your timeline is. But when you start your first job, it's about a coin flip chance that you're going to be in the same job in 5 years. It's better than coin flip chance that you might want to consider changing jobs in the first 5 years. So you're going to want to know what your options are to leave, how painful it's going to be to leave, what are the legal and financial ramifications of exit. And we're going to talk about those and how to evaluate and negotiate those. At its core, I really don't want first contract physicians to be surprised and like find out a couple years in that they are golden handcuffed into a job that makes them unhappy. Representing primarily physicians here, I really don't want to see moral injury and burnout scenarios by physicians that feel like they have no option, their contract traps them in a job and they can't leave for various reasons. So we're going to go through some of those now. The top two wrong questions that I get from first contract physicians that are looking at their first opportunity, they ask if the non-compete is real. Like, Michael, can they really prevent me from working in Orleans Parish and Jefferson Parish? Okay. Yes, they can. Louisiana non-competes are still enforceable, but they can occasionally be beaten out in court. But your physician contract probably is going to prevent you from even getting to court. It's really hard to even see like a publicly disputed non-compete because the vast majority of physician contracts don't allow you to sue in open court in public in a way that's like searchable. Okay. They make you go to arbitration, which is a private matter. They usually pick a more conservative jurisdiction to fight out a dispute, and they require a certain type of lawyer to decide your dispute about physician contracts. And like, no surprise, an employer is typically going to set a venue that is more favorable for them. They kind of stack the deck. So is this gnarly non-compete actually enforceable, and would they really do that to me? Yes, and they will. And it doesn't have to be 100% enforceable at all times for it to do the trick. It's often really hard to find an employer that will allow you to violate your prior employer's non-competes. Most employers actually don't want to hire folks that come with the potential for a lawsuit. Think about all the money that they just spent trying to recruit you, all of the money that they're spending to get you ramped up, get you started, all the money they're going to lose during the first handful of months. If they're in the red by $100,000 on you, and then you get a cease and desist letter saying, hey, working here like violates a non-compete, don't do this anymore, we're going to sue you, they might be out $100,000. Like, I don't know that too many employers really want to take that risk. So yes, you have to pay attention to the non-compete, and we'll talk about more details. Second question is, can I ask for more signing bonus? Yes, you can. And often employers are already, look, in the whole, in the beginning of your ramp up by $100,000 or more. Okay, they're already spending a bunch of money. So will they tack on another $5 or $10 or $15,000? Sometimes, maybe, often they do, but it's really not that important of an issue, frankly, in physician contracting world. Pretty much everything else that we're going to talk about is more valuable than getting your signing bonus from $10,000 to $25,000. Everything else from here on in is more important than $15,000. Some better questions is your exit strategy. How can you leave? If you can easily leave a job and you have developed some value, like you're making that employer money, you're seeing patients, patients are happy with you, staff is happy with you, things are going well. If you've established value and you can easily take that value somewhere else, now in the future, when you need to renegotiate something, maybe you need to renegotiate something about work schedule or something about compensation or access to other resources, whatever it is, now you can renegotiate from a position of strength. If your exit strategy is terrible and your employer knows it, if they know that changing jobs means pulling kids out of school, selling houses, like restarting an entirely new market with new patients, like basically starting from scratch, if they know that, then the odds of you getting the thing that you want 5 or 10 years into your career goes way down. It's just a matter of leverage. What is your leverage going to be, 5 or 10 years from now when maybe you want to negotiate something new. Most physician contracts don't promise a certain amount of compensation forever. It's really hard to do in the physician contracting world, frankly. So the future with compensation is always a little bit in flux. And if you can leave relatively comfortably and take another opportunity, explore other opportunities, then that can be a really great way to protect your future compensation. So yeah. Important piece, how much detail do you have about your job obligations? Sometimes I'll read physician contracts and they'll say, physicians shall earn a salary of $300,000 and work obligations shall be determined in the employer's discretion based on employer need, period. And that is the answer to like the first two questions of the Trinity. It's like, whoa. I don't even know like how many patients are you expected to see? Like how much time off do you have? Like what is the compensation? Do you get a productivity bonus or not? How are they defined? And then also how much autonomy and control do you have? Do you have a measure of protection on like the inputs around you? Lastly, do you understand how you're compensated both now and in the future, and can you enforce it? Future compensation is always quite murky in physician contracts. Okay. You sign on to that non-compete that kicks you out of Orleans and Jefferson Parish if the contract ends for any reason. Oh, and by the way, that minimum guaranteed salary that we promised you, it's only for 2 years. And after that, we have the option of changing it as we need it. The compensation can be changed, but that non-compete doesn't go anywhere. It's still there. You signed up for it, and now it can be changed. Look, on a macro level, is going to change like aggressively in the wrong direction. Usually not. Sometimes employers will like go belly up if they do that, right? They can't recruit anybody else. Like they can't make it work. But whether an employer offers like a high compensation package at the moment that you sign, there's very rarely anything in your contract that like promises that the employer is going to continue being compensating you at a really high rate. So be aware of what your contract says for future compensation. Leverage and exit. Been talking about it for a little bit. I want to make sure that I'm not missing any questions in the text. Don't know that I see it here. Have there been any questions go across?
I don't see any questions yet.
Cool. Perfect. For the leverage and exit clauses, these are the 6 main ways that I see in physician contracts that you might feel trapped in a job that you want to leave. Okay. The non-compete we touched on. The non-compete will often speak to a geographic restriction on where you can work, both during and after employment. It survives the end of your employment. You can't just terminate your contract and be like, yeah, that non-compete doesn't matter anymore because my contract was terminated. I know contract law and you can't do that. Like, yes, you can. That's the whole point of non-competes. It usually lasts in Louisiana. It usually lasts for 2 years after your contract ends. And in Louisiana, you have to identify specific parishes or portions thereof. Occasionally, you'll get an employer from Texas that will use their Texas contract form in Louisiana, and then like that doesn't really work. Louisiana has very specific requirements, but the vast majority of Louisiana employers do it right. They hire competent counsel and they get it right. But you want to know geographically where you are restricted from working. The second is the non-solicit clause. Most physicians develop really valuable relationships during their employment. And the employer also has very valuable relationships with others. Some of the most obvious are with patients, with coworkers, with referral sources, with hospital systems. either you or the employer are going to have a number of contracts with third parties. Often that employer will make it problematic for you through the non-solicit clause to contract with the same people. Let's say you want to leave and you want to tell all of your patients to come with you to your next location, and you want to hire away your favorite MA, your favorite nurse, maybe your favorite fellow physician. Y'all want to start a competing practice across the street. Let's say the non-compete doesn't exist, which would be kind of weird in Louisiana, but let's say it doesn't exist. The non-solicit clause is probably going to prevent you from doing those other things. Sometimes there's a no hire clause in there that prevents you from taking your staff with you. The non-solicit clause on referral sources is a very interesting one in pediatrics, like where the employer gets their referrals from can sometimes be a protected relationship. And if you try to solicit that relationship, sometimes there are legal consequences. Not fun. But make sure we don't sleep on the non-solicit clause. It's usually like right before or right after the non-compete. A lot of physicians will say, oh, I read that non-compete. I listened to so-and-so say I should know it, and it's whatever, so I'm good. You know, maybe the non-compete doesn't actually affect you that much, but often the non-solicit will have some impact on your ability to utilize, to leverage the valuable relationships that you develop during your employment in your next opportunity. Tons of variance in non-solicit clauses, by the way. They really churn my stomach from a lawyer side, because it's not always crystal clear what you can and can't do upon exit. Very difficult sometimes to say precisely when a physician is in trouble under the non-solicit or when they're completely safe. Another important issue, term and termination. When most employers, like, they explain what the job is, they'll say something like, you know, this contract is a 2-year contract and it pays you whatever, and you got to do things at these locations. Okay. What does a 2-year contract mean? Most first contract physicians, before, you know, someone like me works with them, they think, oh, 2 years, like it's kind of like residency or fellowship. Like I'm kind of stuck there technically. I guess technically I could leave, but it would be incredibly problematic. Like it's really difficult to transition out of a residency program, right? So often that's what physicians think about the initial term of the contract. However, it should not be that way. Okay. The vast majority of physician contracts have and should have what's called a termination without cause clause. You and the employer should have the ability to exit the relationship at any time, including, like, unlikely, but including from like day one, you should be able to get out. But you usually will have about a 90-day to 180-day notice period. During that notice period, you and the employer got to keep doing things the way that you were doing them before. Everyone's got to act in good faith, and you continue to see patients. You're not throwing grenades in the office. Like, everybody is just being an appropriate professional. Make sure that you have the right to terminate your contract right away. I'll see this slipped into contracts where it'll say the term is for 2 years. After the initial term, comma, physician and employer, you know, shall have the right to terminate without cause and for any reason upon 90 days notice. Okay. That little phrase in there, after the initial term, comma, that means you can't leave for the first 2 years. And if you do, you might get sued. I've had to, like, defend this lawsuit on behalf of a physician under a 3-year no-out contract. It is not fun. You could certainly get, this happens more often in smaller independent private practice settings, to be honest, but you could certainly get an employer that's kind of frustrated, that said, you know what, look, I spend $100,000 to bring you on and get you ramped up, and now you want to leave. I kind of want to sue you and get my money back. So make sure under the term and termination clauses, you understand what are the rules of exit. Cool. Malpractice tail insurance. For the vast majority of employed situations, your employer will pay for your malpractice insurance for any claims that arise during your employment. Okay. Let's say you start a job on August 1st of 2024. Okay. You're in training, you're about to start your new job August 1st. Let's say you work there for a year. Okay. Let's say you committed malpractice, unfortunately. If that claim was made against you during your employment during that year, then pretty much every employer is going to have a malpractice policy in place, and that policy is going to provide coverage. Okay. Sometimes, though, they do not provide coverage for claims that are made after you leave a job. Okay. Let's say you work there for a year. You're like, oh, I don't like it here. I want to do something else. I want to pivot. Your last day is July 31st of 2025. Let's say you committed malpractice, unfortunately, but the claim, no one made the claim until after you left that job. They made it on August 1st of 2025, one day after you left. To have insurance, malpractice insurance, to cover that claim, you might need to buy a separate policy. Sometimes the employer also pays for that claim, but sometimes the employer makes you pay for that claim. It's called malpractice tail insurance. Tail meaning like after you left the job, tail. You want to know who's responsible for buying that malpractice insurance policy. It can be quite substantial. It can be quite expensive. It's almost certainly going to be a 5-figure expense upon exit. If you happen to have a couple claims, that it might be a little bit higher, but you can expect that if your employer doesn't pay for tail, then if you learn what they pay each year for your malpractice insurance, let's say it's $8,000 a year to cover you for malpractice, you can usually add 1.5 to 3x of that, and that's going to be a range for your tail exposure. So it's often something 15, 20, 30, $40,000. It can be something in that range depending on location and length of service and claims history. There's a lot of moving parts, so I can't tell you for sure what your tail is going to be. But it's a real number, and it's often a very negotiable piece of your exit strategy, an additional cost.
Decoration.
An additional cost that an additional cost. If there's any questions, like feel free to jump on. It's totally cool, by the way. But it's an additional cost that you need to take into account before you leave and have a plan. Maybe have some money in a savings account so you're not like surprised by an unexpected expense upon exit. Malpractice tail insurance. The fifth one is compensation clawback and waiver issues. Going back to our signing bonus question, y'all get particularly first contract physicians, you get very excited about money that's paid to you before you start. Okay, your signing bonus, you get $25,000. That's as much as you made in the last 6 months in your residency program, and that's really cool, right? However, anything that you're paid before you start like that is really money that is paid to you for work that you haven't performed yet. In almost every situation, that $25,000 signing bonus will come with a service obligation afterwards. Usually it's anywhere from 1 year to 5 years. If it's a really big number, it's probably going to be a little bit longer. If it's a little smaller number, then 1 year sometimes is all they require. But let's say 2 years, let's say 3 years for $25,000 is in your contract. Sometimes if you stay for 2 years and 364 days, okay, you didn't make it to 3 years. Sometimes they'll demand all of that money back from you, plus interest. Interest is pretty high right now. So like the $25,000 could certainly turn into $30,000 in 3 years or in 2.5 years. So it can get expensive. Okay, so you want to know the details, particularly if you have a big signing bonus. Look, if you get a signing bonus and relocation of like 5 or 10K, that's probably not going to golden handcuff you. Okay, you're probably gonna have enough money to pay that off and get out of your contract. But if it gets big, you really want to make sure you negotiate the details about when and how much you might have to pay back if you leave your job within the first few years. Remember, 40% of physicians, something in that range, will change jobs within the first 2 to 5 years. So the details of the clawback issues for your signing bonus can become quite substantial. Also, here on the waiver issues, we want to watch out for massive bonuses that are paid once a year, because sometimes the details around that bonus and when it's paid are frankly not very fair. Let's say, for example, you typically earn a total of $300,000. You get $200,000 as your base, and then once a year at the end of the year, they add up how much collections you created, and they give you a percentage of collections. Let's say that's the compensation model, and you get a $100,000 check. Sometimes the details around when you receive that money can be very punitive. Sometimes the contract will say, look, let's say you stayed for 9 months out of that 12 months and you were on track for $100,000. The fair way to do it would be for you to be paid $75,000, obviously. But a lot of physician contracts will say, nah, like you get zero of your bonus unless you stay for the entire measuring period. Something to pay attention to. Sometimes that's negotiable, sometimes it's not. It really just depends. But at a minimum, it's something that you need to know when you go to plan out your exit, right? You really don't want to be surprised by that if you get a big bonus and then you realize, shoot, like I could have stayed for a couple more months here and I could have gotten my bonus and then submitted my notice of termination after that. Watch out for unfair details around your compensation plan, particularly bonuses and whatever they pay you before you get there. Your one-off sweeteners is how I like to call it. But any questions about compensation clawback and waiver issues, please let me know. Lastly is moonlighting and exclusivity. Some contracts will allow you to leave relatively some contracts will allow you to work in the clinical practice of medicine outside of your primary employment. Some won't. If moonlighting is important to you, you might want to know about it, potentially negotiate whether your job is exclusive or not. Having a second source of income can be very helpful when you're planning your exit. Being able to ramp up a little bit of funds and earn a little bit more can be very helpful. So something to inquire about. I have a chart here. Let's talk about like a good job and a bad job for exit strategy purposes. Let's say you're a first contract physician and you get a job and you go to the bank and you buy the most expensive house that you can possibly afford. They'll give you a bunch of money, by the way. You buy a $1 million house on a $250,000 salary, they'll probably give you the money. Okay. But your non-compete, let's say you want to leave after a year, your non-compete sends you outside of that parish and like the 3 surrounding parishes. You got to leave town. You got to sell that house. Selling a house in 1 year is you're probably going to lose about 7 to 10%, maybe up to 15% of the value of that home through various costs and everything. So if you have you have to leave town non-compete and you need to transition out of your job very early career, that might be a $50,000, $100,000 problem. Same idea for the non-solicit clause. Non-solicit clause can be as punitive as a non-compete, can make it very difficult for you to remain working in your community. Malpractice tail provision, if you have to cover it for a relatively early career pediatrician, that might be a lower 5-figure number. The details around term and termination can be rough. Sometimes you have the no-out contract and you literally can't. The length of the notice can have a negative impact on how much money is coming in when you're transitioning between jobs. Okay, if that notice period is really short, let's say you submit your notice of termination and the employer can let you go in 45 days. Man, you're probably going to miss some paychecks. Like, I don't know too many employers that can get you ready to go in 45 days or less. So missing paychecks during a transition between jobs can be very costly. So watch out for that as one of the financial costs of exit. Same for the compensation clawback and waiver issues. Let's say you got to pay back all of that $25,000 with interest. Now you're at, I don't know, 27, 28 after 1 year. That can be pretty rough. Or you can negotiate it as like reducing over time. So let's say it's a 2-year clawback on 25K. It'd be much better to pay back 12.5 after 1 year instead of all 25K. That's something that is often quite negotiable in a physician contract. And then moonlighting, being able to moonlight can help you transition. A little more money in your pocket. It can help mitigate some of the other exposures in your exit strategy. It really just depends on what you want to do and how you want to practice, but it can be an improvement on your exit strategy. So look, all in the same type of contract. Let's say you get a contract, 2 options. One, they're both going to pay you $225,000, okay, with a $25,000 signing bonus. These exit strategy details can flip the financial costs of exit by a massive amount of money. Okay, if you have a contract with the you have to leave town non-compete, now that's going to have massive financial implications, also social implications as well. But this type of math problem is often missed by first contract physicians that frankly don't read their contract. Their employer tells them like, hey, don't worry about hiring a lawyer. It's not negotiable anyways. You don't need to know about this. We told you everything during the interview process, blah, blah, blah. They say that, and then all of a sudden you have a massive exit strategy cost, and you go to like try to leave your job after a year and you realize like, I don't have enough money to leave my job. I don't have enough money saved up to navigate all of these exposures. So before you sign your first contract, or if you're in a contract right now, seriously consider like understanding what's in there so that you can plan. Advanced planning at a minimum. Couple compensation issues I want to discuss. There's a group called MGMA, Medical Group Management Association, and they produce a bunch of compensation data. There's other groups that do it, but MGMA is the biggest. I think Oshner prefers Sullivan Cotter, but there's other ways. Sometimes it's others will do it as well. But for general pediatrics, I have access to this data. And looking at it closely, I realize it's a bunch of numbers jumbled at you, but we're going to walk through it. Don't worry. But when you look at it closely, there's some important trends that pop up. Okay. Let's start off with the middle trend here, total compensation. The first column is an academic assistant professor, so someone relatively early career. I realize this says national, but it's actually the South, so I apologize for messing that up. I'll correct it before I send it out. But a general pediatrician in an academic setting at the rank of assistant professor in the South is typically going to make between 159K and 199K. Okay, general starting range. Now, if you go to the other end of the spectrum, if you're in a physician-owned private practice in the South, that same range, that 25th percentile to 75th percentile, is going to be between 221 and 473. So basically, the physicians that are owning their own practice and are frankly quite busy and maybe are making a little bit of additional money off of folks that are employed by them, okay? They have a business that they own. The 75th percentile or higher is going to be at 473 or better. Okay. So there are certainly pediatricians making over 500K, but it's really, really hard, exceedingly rare to do that, frankly, in a hospital setting or in an academic setting. Another thing that I want to really highlight here is compensation as compared to volume. The vast majority of physicians are actually paid on volume and not on the quality of their work. That sounds incredibly like cynical, but that's how we compensate physicians for now under the vast majority of payor contracts. Slowly that will adjust. There's value-based metrics that are being worked into a lot of contracts here, okay? But the volume of your work is going to have a massive impact on your total compensation. So when you go across practice settings, you'll see some very clear differences. On the lower end of the busy scale, if you will, for an academic assistant professor, you're looking at 3,100 work RVUs. But on the busiest end of the physician-owned private practice side, you're at 9,000. So like 3 times as many RVUs. One thing that I find very interesting is that when you compare volume to total compensation, there's a reversion to the mean for the amount that a physician is paid per unit. Here we'll see for an academic assistant professor, the 25th percentile and the 50th percentile is 36 to 41. That is almost the same as physician-owned private practice in the South. In hospitals, like maybe there's a slight tick up in the amount that you're paid per unit, a little bit, but not like, I guess on the macro level, maybe it's meaningful. But generally speaking, the amount that you're paid per unit is relatively consistent across practice settings. A lot of physician-owned private practices, physicians who own their own private practice in the South, or work in that practice setting, are often making around the same amount per unit as academics, and then in hospitals it bumps up a little bit. Hospitals somehow don't actually have to make money. Sometimes they make money, sometimes they don't. But physician-owned private practices, they have to make money. If they don't make money, they close, right? So that's where we see some of the norms. So at the end of this, I realize it's a lot of information to throw at you, but here's the punchline. Understanding the data, particularly as a first contract physician, is important to understand your worth in the market. I would encourage you to ask your residency program to buy this for you and actually like have someone teach you like how to use it, how to read it, like what's going on. Okay. And then using updated data is important. This is data based on 2022. Like, don't go back to this presentation 5 years from now and just assume all the numbers are the same, because they're not going to be the same. They're certainly going to change over time. And you really should use the most updated data. But for a comp, okay, when you compare it to work obligations, you really can't say a pediatrician makes X. That's just not true. We go back to this slide. The lower end of academics is 159. The higher end of physician-owned private practice is 473. That's 3X, okay? But a better question, or like a better statement, if you will, would be for a pediatrician insert the practice setting, in a specific geographic region. These numbers shift around a lot based on geography. They can be higher and lower based on being in a big city versus a rural area versus a different area of the country, okay? They vary based on geography. With volume expectations of whatever the volume that you're expecting to do or that the practice expects of you, okay, then the data suggests a compensation range, not an exact number, by the way, a range of X. This is more important, frankly, than knowing like what is the minimum guaranteed salary during the first year. If you're like first contract physician really wanting to know what does this job mean for me, for my career goals, for my life plans, what does future compensation and work obligations look like? Going back to our main theme of the Trinity, is understanding compensation and obligations. You'll want to know this, okay? What does this particular employer expect from me in volume, and how am I paid? Does my compensation go up with volume, or does it stay the same with more volume? Sometimes you don't actually have a productivity bonus. You might want to talk about that. What we want to avoid are compensation models that are outside of these norms. If you come to me and say, look, this employer is going to pay higher than these ranges for a low volume, I'm going to say, nah, probably not. Like if they say that now, like something's going to change, they don't have to. There's ultimately a reversion to the mean on compensation to work RVUs. You know, you might be above that for a little bit, but ultimately you'll probably be back inside of that range around the median or maybe slightly less than the median, frankly. Okay. Very rarely do we see jobs that are consistently like wildly above the norms for practice setting and volume and geographic region. So understanding what the market calls for your services can be very important to navigating physician compensation plans. How are we doing? Did I put everybody to sleep? Maybe. Feel free to jump on. Let me know if you have any questions. I usually get a lot of questions around non-competes and around kind of trying to map out your exit strategy costs. No questions. Let's look for a moment during our last few minutes here at geography. This is an example from North Carolina, but in Louisiana, if you look at a non-compete, it's almost certainly going to list out parishes. So you don't do bubbles, like geographic bubbles. You look at the parish and say, okay, I can't work within this parish for however many years, probably 2 years in your contract. If you're going outside of Louisiana, the vast majority of states will have a radius that you can't work in. Okay, they'll say 15 miles, 30 miles, 5 miles from some location. Sometimes they say multiple locations, by the way. If it's a private practice with 5 locations, sometimes they'll say from every single location where we have a clinic. Okay, sometimes you don't want to have a multiple location non-compete. That can be really painful. But if you have one that's based on miles, it's almost certainly going to be based on radius, not on Google Drive time. You can't go to your iPhone and like punch in how far it is from one practice to another, because that's going to take you like this, especially in the back roads. And that's not how your non-compete defines miles. They're going to do it as the crow flies, a radius. So I would encourage you to go to a map, pull up the radius, look at it very closely. This is an example. I think it's Harnett Health in like central North Carolina. But just look at it and say, okay, on the front end, I've got to assume for the moment that this non-compete is enforceable exactly as written. So what would it mean for me to not be able to work within this geographic region for 2 years? Consider negotiating it down. A common negotiation tactic is on time, trying to reduce the length of the restrictive period, ask for 1 year instead of 2. Sometimes you can carve it out based on who ends the employment. You know, if you end the employment, then they probably want to enforce a non-compete. But if an employer terminates your contract without cause, then why should they enforce a non-compete? Like, that seems unfair, right? That's a very common request that I propose when I'm negotiating contracts. Dr. Gerald, what site do we use for the radius map? There's a few on Google. I think this was Calc Maps or maybe Maptive. Maptive had like a really good free version that I used for like a year and a half, and then they kicked me off. So I think that's from Maptive, but there's a couple different options there. Yeah. Let's make sure I didn't miss any questions here. Yeah. Number of different ways to negotiate. I guess last part, like parting thought here, for folks, unless you have any questions. A lot of first contract physicians will be told by the employer that the contract is sacred, not negotiable. Everybody signs it. It's standard. It's boilerplate. Sometimes that's true. Sometimes it's not. All right. Just saying that they don't negotiate shouldn't be the end of your discussion. Okay. And also think about it. They get a lot of money riding on recruiting you. It costs them at least a six-figure number pretty much every time that they bring on a new physician. You should expect a certain measure of like puffery. Okay, this isn't like a free game for them. There's a lot of money on the line. There's a lot going on here. So just because your employer says like, yeah, it's standard and we don't negotiate, at a minimum, you should understand your contract. You should understand the pros and cons of compensation and obligations. Make sure you understand your exit strategy. Seriously consider getting with someone like me or someone who really knows the ins and outs of physician contracts. Not every lawyer knows this, by the way, but someone who does physician contracts, and talk to them about it and say, okay, what are the most problematic aspects of exit? Okay, work through your contract and figure out, okay, if I was going to ask for something, what would it be? What would be most important to me and why? And then when you're like informed, you really know what's going on with your contract, then it can be successful to pick out a couple of important issues and ask for them to change it. Like, look, are you going to change every single clause, like every single provision? Probably not. Okay. Vast majority of physician contracts are written by the employers in their favor. Okay. They're not written for you, they're written for employers. But you can often pick out a handful of priorities and get some movement on something that's important to you. And even if you don't, I think it's important for physicians to understand and advocate for themselves. So that's my last thought. If you have any questions, any follow-ups, I'll send my slides over, but feel free to add me on Instagram here at Physician Contracts. Type in Instagram at Physician Contracts. I have a lot of fun with this. And then feel free to check out my website, physiciancontracts.com. And here's my email address. I'd love to chat with you.
Hey, thank you, Mr. Johnson. I will be sending out some of that follow-up information, as well as the link to the evaluation. And I am going to put the QR code to that evaluation up now. Even if you do not need credit for this activity, we ask that you still do the evaluation. It helps us continue to improve our offerings and to keep all of your needs in mind. I'm going to drop that also into the chat. Let me see if I can get that up. And then our next pediatric gumbo activity will be on February 8th, and we will have representatives from the Louisiana Women's, Infants, and Children, or WIC program. You can register for that. The same place you registered for this one at pediatricgumbo.eventbrite.com. We will also be having another webinar outside of the Gumbo series later in February on the 27th in the evening. And this will be from a representative from the Frameworks Institute, boosting public discord, evidence-based strategies for reframing child and adolescent immunization. This webinar is all about talking about immunization on the public stage. So in social media, blogs, other situations where you might be speaking as a physician on the public stage rather than one-on-one with the patient. Our conference will be August 16th through 18th in Alexandria. The call for proposals is open now, and the deadline to submit a proposal is February 9th. So please consider submitting a proposal for that. And then you can find this webinar once I finish editing it, and all of our on-demand education at our YouTube page, which is LAAAP on YouTube, or Louisiana AAP on YouTube, and there's a bit.ly code to get you there. Okay, thank you again, everyone, for attending. And it's now 1:02, so I'll let you get back to your day. Thank you so much.